My name's Ellen Cohn, and we have 40 minutes for the entire session. So the poster presenters will introduce themselves and present for 5 minutes, leaving 2 minutes for questions. Actually, I think what we'll do is we'll do all the questions at the very end. That worked out really well for the last session. If we don't get your question about a poster, please feel free to contact the presenter directly. All poster presenters can be contacted on the Summit Event Mobile application under the Attendees tab or the Send a Message tab on the presenter's profile page. So we want to remind you to take time to vote. It's really important to vote on your People's Choice Award winner. Thank you again for joining us, and thanks for all the AV support. And we will move ahead to Ahmed, who had such great questions in our last session. And thank you for that too. Okay, we'll move ahead to Ahmed's slides, please. There we go.
Okay, so my name is Ahmed Alaban. I'm an emergency medicine physician and telemedicine and digital health fellow at George Washington University. And our study today about the role of telemedicine in calculating the Centaur score. As a telemedicine has been a prominent tool, we may need to validate some of the clinical decision rules that have already been validated in the in-person visits. And for example, that specifically today I'm talking about the Centaur score. Sore throat due to pharyngitis is a common symptom in the emergency room and also in the telemedicine encounters. And Centaur criteria is a validated tool that help the physician decide the cause of pharyngitis if it's due to group A streptococcal infection, and in that case, you will need antibiotics. The Centaur criteria has 5 elements, including the patient age, fever, cough, and anterior neck lymph node enlargement, and tonsillar exudate or swelling. If the patient gets a score of 2 or more, then the patient gets the rapid strep test. If the patient gets a score of less than 2, then there is no need for testing and the strep infection is less likely. And our objective from this study is to measure the inter-rater reliability between the telemedicine provider and the in-person provider in calculating the Centaur score. And we specifically compared the testing score of 2 or more and the non-testing score of less than 2. This study was conducted at George Washington University Hospital emergency room and urgent care clinics. And patients were enrolled if they have a chief complaint of sore throat or similar symptoms. And research assistants were enrolling the patients. And the research assistants were asking the Centaur criteria elements. And then they were checking the patient anterior neck lymph nodes for any enlargement. And then they were taking short videos for the patient's throat and then upload those videos to OneDrive. And then the telemedicine provider was checking those videos and decide on tonsillar exudates or swelling. And then an in-person physician decide on the Centaur score for the in-person evaluation. And just before this study, we did training for those research assistants on how to examine the anterior neck lymph nodes and how to visualize and capture images for the throats. So this study has 2 telemedicine providers and 1 in-person providers, and we calculated the CAVA score between the in-person and the telemedicine providers. And in a separate analysis, we calculated the CAVA score between both telemedicine providers. The study sample was around 40 patients with an average age of 31.9, and 43% of them were male. And the in-person provider gave a testing score for 15 patients and non-testing score for 25 patients, while both telemedicine providers give an identical result where they give a testing score for 17 patients and non-testing score for 23 patients. And the CAVA score for inter-rater reliability between the in-person and telemedicine provider was 0.68, which shows a substantial agreement, while the CAVA score for inter-rater reliability between the 2 telemedicine providers was 1, which shows a complete agreement. So this result may motivate future studies to validate the use of Centaur criteria to be calculated by telemedicine. And another point, as both telemedicine providers were in a complete agreement, That may signify the reliability of using telemedicine as a tool to calculate the Centaur score. This study has some limitations, including the low sample size due to low recruitment during the COVID-19 pandemic. And also the videos were taken by the research assistant and not by a physician in real time. In conclusion, we think this study supports the feasibility of using telemedicine to calculate the Centaur score, and future studies should focus on prospective real-time collection of data through telemedicine. Thank you, and I'm happy to take any questions.
Thank you. We'll hold the questions till the end, if that's okay. Okay, that was wonderful, just wonderful. We're going to move now to Rebecca, and there you go.
Hi, everybody. Rebecca Einwohner from Pittsburgh, and I want to tell you about the poster I'm presenting. It's Does Health Center Staffing Predict Diabetic Control? So by way of background, diabetes is a leading health condition, and they're growing numbers. Many patients have suboptimal control. Supplementing diabetes in-person care with virtual care can really help out with glycemic control, that's sugar control. But really how workforce fits into that is something I wanted to explore. Workforce studies pre-pandemic showed the benefits of including behavioral health and other members of the workforce, but not really in terms of workforce studies. And workforce studies pre-pandemic, there was one through the Uniform Data System, and they found no significant relationship between adding in telemedicine and benefiting the glycemic control. So in this project, I was inspired, and I wanted to tie together the workforce issues and the emergence, more telehealth coming out there, and some machine learning I did last term. I looked into the workforce telemodalities, teleuse. The methods I used were included some machine learning methods. I had some independent and 30 independent variables, which were taken from the Uniform Data System online database. And the target or outcome was the percentage of patients at centers who had elevated A1C greater than 9.7, which is pretty high. And the independent variables were all sorts of workforce members, nurse practitioners, dentists, ancillary support staff. And I used some different machine learning methods called linear regression and linear SVR. And I also used a non-machine learning method to break up the data set, select out the best variables, and see which ones of them could be predictive of this outcome, which was the target of patients. I looked to see which models performed the best. So using some different techniques. Moving on to the results, I want to tell you a little bit about it in the center column. So out of the Uniform Data System, there were 28.5 million patients who were surveyed in the 2020 survey, and some over 20,000 were diabetics were included. But if you look in the center column, you're going to see that out of 1,375 centers, some 1,362 or most of the centers use some sort of a telehealth. And really most of them. And that's really different from the prior study that I mentioned before, when telehealth was not found to be really, predictive of the outcome. And you'll also see most centers used one modality, but fast forward, some of them use two and some of them use four. And you can see that breakdown there. And then in terms of the models that I use for the regression, you can see about the performance. The peak performance that I got was in the range of 0.6 to 0.8, if anybody's listening in on what's going there. And I also use a non-machine learning generalized regression model to see, and on both of these I use to identify the top features or variables in that list of 30 variables in which were predictive. On the bottom picture, I want to show you something I found really interesting. And what these feature scores are is talking to you about variables and what's their relative importance in predicting that target of diabetic control. And you're going to notice on the far right, so there's a feature score, there's a variable listed. On the far right, you're going to see a grouping, and it looks like some things just look like they mean more, right? So what that really is who are the most predictive variables out of all those things tested? Televisits, dentist visits, in-person visits, ancillary support staff. And the ones that were really flagged a lot, I thought, were which telemodality was used. And that really meant a lot to me. when I was going forward. Now, I want to get a little bit to the discussion and conclusion is that this exercise showed that some of the machine learning models can have some utility when using the workforce to try to predict out the target. And using those models, there was really not much of a benefit of adding in any telemodality use, but the importance of the workforce really came out, and also the importance of adding in telemodalities. And I hope that as teleprograms are built more and more, that's going to be included, the members of the workforce and including in, and the most featured ones, remote patient, combination of remote patient monitoring, storing forward, and also real-time storing forward. So keeping these in mind as we build programs for targeting glycemic control. Thanks.
Wow, great analytics, terrific. Okay, thank you. And thanks for staying on time for us. It helps a lot. We'll move to Deborah now.
Did you have a microphone or are you just?
No,
It's right in front of you.
It's right here. Oh,
Hi,
but
Deborah.
I'm not.
We're just seeing your,
But it's a new blouse and it's really
very
pretty.
nice, very nice.
Okay. Okay.
Right,
How is that?
perfect.
Okay, thank you. I'm Deborah Graham. I'm a doctor of nursing practice student graduating this Friday, 10 a.m., University of Texas. at
Yay.
Charlotte. I have my references and contact information there in the QR code. So it was a combination of me in my role as a director of informatics for a large physician and nurse practitioner group that provides services to long-term care and skilled nursing facilities in Florida, and COVID, and being tasked to set up a telemedicine program before COVID. So it was through that it was, wow, we're using telemedicine to see our COVID patients with our existing nurse practitioners. That's going well. In that first year, we did about 2,500 visits. But we had a rising an elevation of return to hospitalization and transfers to the emergency departments from those 4 of the facilities that we were providing services for. So we said, well, wonder what happens if we take the successes we're having with telemedicine internally with our nurse practitioners and do this 24/7. Can we bring a provider to the bedside either in person or via telemedicine? So that was our problem. And I just want to point out too, because I'm applying evidence here. This is not research. This was not a study. I went to the bench and looked at the evidence and applied it 100% to our population to see, and the purpose was to apply that to our existing 4 centers that had rising readmission and transfer rates with the goal of reducing those. And then using the solution of the telemedicine after hours at change in condition. In the very center of the poster, I had permission from Dr. Stadler to use a protocol that he calls Call Us First. And so that's how I branded this. And it's really, just activating the healthcare system based on the change of condition of the patient. It's not rocket science by any means, but it gave the nursing staff within the facilities an organized template that was built within their electronic record. And what we found was when the protocol was followed, that in 2 of our facilities that we did meet or exceed the reduction in return to admission. And that was 4 to 11%. So DeLuna and Arcadia met or exceeded that. And what I also found to the top right results and analysis was that utilization of the protocol didn't necessarily equate the results. But the video visits did. So the higher concentration of actual video visit had a bigger impact in our results. Conclusions and implications: that when you're implementing telemedicine in a nursing facility, it doesn't matter how much that leaders, the owners, the physicians want it. If the nursing leadership was not behind it, we did not have success. that the higher percentage of those video visits didn't increase our positive results, and that the licensed independent practitioners, that our staff loved it because it decreased their call. But in the centers where we did have mixed providers, that we weren't the only neck to grab, I like to say, when there are multiple different physicians or groups to call, those centers had some difficulty remembering what to do when. And I thank Matrix for allowing me to not only present my poster, but I was also a peer reviewer, and that was a lot of fun. And I look forward to your questions after. Thank you.
Thank you so much. Thank you so much. Wonderful. Okay, we're moving on to the next poster. Shiv, I hope I said that right. How do I say your first name the best way?
Shiv is not here. I'm Dr. Dang. I'm going to be presenting for him. He had a conflict. It's the end of the semester, and
Okay.
Yes.
We're happy to have you. Okay, go ahead.
Let's see. Okay, yeah, this poster, I guess, is a different layout than the others, so it's going to be a little bit harder to read. But so I'm Studi Dang. I'm a geriatrician at the Miami VA and the University of Miami. And she worked on this project with me. This is a project that was funded by VA HSR&D to use peers to assess unmet needs in high-risk veterans who are at risk of being placed in a nursing home. So it's not quite where the last presenter was talking about patients, but these are patients who are at risk. And we know in the VA, based on VA analytics, that less than 50% of the people who are at risk for nursing home placement have used any kind of supportive services or home care in the previous year before they end up in the nursing home. So we thought we would try and bridge this gap by using peers who don't wait for the patient to come into the hospital or to the outpatient clinic, but rather go to the veteran's home after identifying them from a high-risk list that the VA puts out every quarter. So in this project, we decided to we hired 2 peers for the project. They are funded actually through the VA Mission Act, which wants peers to be at every facility in the VA. And we train them to do home visits by working with the home-based primary care team, which is a team that provides longitudinal primary care to veterans in their home. And after rotating with the peers and the HBPC team together for a week, we came up with a checklist that the peers would use to identify all the high-risk criteria that the veteran met and the needs that the veteran had that were not being fulfilled. Again, this was based on many years of experience with doing home care by several people who were involved in the project at multiple sites. So the way the project was structured was that every patient from the list that was generated every quarter would get a call and be asked if they would be interested in allowing the peers to work with them, to do a video visit, and to do a home visit. We wanted to structure this program for everyone to have the option of having a video visit if they were able to do a video visit, which was a challenge in itself. And if they were not, then the peers would go to the home. The peers would go to the home regardless, but the video visit was what we were trying to encourage before the home visit happened, to try and figure out the differences between the two possibilities. And then the program itself offered, after the unmet checklist was completed, the peers then worked with the primary care providers to make sure that all the unmet needs are addressed by working with the whole team in the primary care clinic, which includes the social worker, the pharmacist, the nurse case manager, etc. So in this initial analysis, the very few patients are included that had a home visit. The end, when we did this data analysis, was only 8 patients who had a home visit. And about 19 patients who'd had, 8 patients who'd had a video visit, and 19 patients who'd had a video visit plus a home visit. So this project, as other projects that have been presented today, was funded during COVID. So we had to kind of turn how we were doing the project and include this virtual piece very quickly. which wasn't necessarily an initial part of the project. So we see in this table in the middle column on top, table 1, that shows that really there were no differences between the people that were either getting the video visit or the home visit. In essence, the only differences that we see, which were not significant, were in their CAN scores. So the people who had a home visit and were not able to allow a video visit had a higher CAN score and a higher GFI score. Those are the last 2 rows in table 1. Again, the differences were not statistically significant, but that's probably because of the sample size that we have, which shows that the people who did not complete a video visit or were not able to complete a video visit were sicker and frailer than the ones who were able to complete a video visit. In looking at okay, that's my time, I guess. So I'm going to stop, but I just wanted to mention that if we look at the graph below, if we look at the home safety devices, which is the third column of bar graphs from the right, it shows that the home safety devices or the home safety challenges were picked up actually better by the video visit or on the video visit, because that's a longer column than the others. So it shows.
Thank you so much.
Pretty effective. Thank you.
I really appreciate this because I'm helping out my 98-year-old veteran dad. And these home visits are amazing. So home supports really keeps people going and in their homes. So thank you so much. Well, we have, last but not least, before we get to questions, we've got Pinky, and we've been in touch through the day to make sure we're all connected. So I'm glad to finally meet you.
Thank you. Hello, everyone. My name is Pinky, and I will be presenting on the implication of an advanced practice provider-led telehealth quality program at Jefferson Health. Jefferson Health is one of the largest employers in Philadelphia region. It has been an early adapter of the National Quality Forum's conceptual measurement framework as the foundation for measuring telemedicine outcomes. Hence, this unique advanced practice provider role was created to educate, standardize quality measurements, and adopt the NQF measurement framework throughout Jefferson Health's 18 hospitals and ambulatory practices. We will discuss how this APP-led quality and process improvement program improves the care delivered through the telehealth in the domains of access, cost, experience, and effectiveness. The first domain that we'll discuss is access. We improve access to care by offering virtual on-demand visits, scheduled visits, asynchronous e-visits, and virtual rounds. Jefferson's on-demand visit, also branded as Jeff Connect, serves patients 24/7, anywhere, anytime, and from the comforts of their home. As we know, COVID-19 pandemic has drastically changed the landscape and scope of telemedicine, where our on-demand visits, which were in 2000 in FY 2019, went as high as 12,000 in FY 20, above 21,000 in FY 21, and we're about over 9,000 for FY 22 so far. Similarly, the scheduled telehealth visits increased from 3,000 yearly pre-pandemic, going as high as over 335,000 for FY 21 to now over 200,000 for FY 22, which is 12% of our ambulatory visit volume. The second domain that we'll discuss is effectiveness. We adapted several measures to improve the effectiveness of telehealth programs. These include standardized onboarding of new providers, provider training for effectively conducting telehealth visits with the inclusion of physical exam modules, training to use virtual platforms, and training to document effectively. In addition, we monitor effectiveness through key performance metrics, auditing, and provider feedback. An example here is completing chart within 24 hours, where most of our providers complete documentation at the time of visit, or at least by 24 hours. To reduce variation in practice and deliver evidence-based care, we developed clinical pathways for 48 clinical conditions. 32 Epic Progress Note templates were created, and Epic order sets were created for the top 10 clinical conditions seen through on-demand. The third domain we'll discuss is experience. We monitor patient surveys to improve patient experiences and also our processes and strategies. For the scheduled visits, we could see that above 84% of the patients indicated that video visits made access to care easier. Above 83% indicated video visits were easy to use. Above 71% indicated they received same level of care as an in-person visit. And above 91% indicated they had enough time with their provider. Above 86% indicated they would use video visits again. Lastly, we could see our Net Promoter Score, which rates how likely are they to recommend Jeff Connect to their friends and colleagues, is above our goal of 50. Finally, the last domain we'll discuss is cost. Telemedicine saves not only cost, but also time of the patients. Based on the survey responses, we could see that above 74% of the patients indicated they saved money for parking, gas, tolls, and other travel expenses. Above 83% of our patients indicated they saved 1 or more hours of their time doing video visits. And you could see in the graph, majority of the patients said that they saved 1 to 3 hours of their time, which is incredible. In conclusion, our journey to develop this telehealth quality program was not as straightforward as it appears. Quality metrics for in-person visits are well known and defined well in several literature. However, despite the extensive use of telemedicine across the nation, quality measurement for telemedicine is still in development. We have gone through the times of ambiguity, trials, to hardworking and dedication of our team members to develop this quality program. Using the NQF framework, this quality program helped us to increase access to care, decrease its cost for the patient, improve patient and provider experiences, and allowed for effective, safe, and timely care. It has opened the door for ongoing quality monitoring and performance improvement, advancing telemedicine scope, and redesigning care model. Thank you for having us present today.
Thank you. And these are all very strong. Wonderful. I hope you're all publishing them. Excuse me. I think I might need that center score. Is Ahmad available?
Yeah.
Ahmad, how, I've never heard of that score before. I work in cleft palate. I've had, kids at the pediatrician. That's pretty interesting. Is that well used at this point?
Yes, this is very commonly used criteria in the emergency room, and we can use it also in the pediatric population from age of 3 and above. So, and we use it like in my practice, like I'm using that on a daily basis.
Oh, it's great to know. That uvula looked a little bit asymmetric, I just want to mention, and swollen. Okay, how about questions from the floor?
I have a question about that. So into a triage situation in your emergency department, is this something that like the triage staff can do, or you're encouraging them to do it even before they get there?
So when the patient comes to the emergency room, there is a research assistant. They will track the waiting room board.
Yes.
And they see which one of the patient has a complaint written on the board as a sore throat, or similar stuff like scratchy throat, painful throat, something like that. And then they will approach that patient and explain the study for the patient. And if the patient agrees, so the patient get enrolled. And they go through the inclusion and exclusion criteria and things like that. So this is how we were enrolling patients from the waiting room of the emergency room. Yeah.
Thank you.
Good.
Oh. I'll ask you another one. Did you pick up submucous cleft palate when you're looking at the photos?
What is that? Sorry, I couldn't hear you.
Did you pick up submucous cleft palate when you took the photos? If you did, you should publish that. Okay. Okay. How about more questions?
So I have a question for Pinky. So the numbers are the percentage on the experience and the cost part were based on how much total patient were surveyed.
For the scheduled visits, there were 18,000 patients. Yeah. And for the on-demand, which is not published here, there are about 6,000.
Thank you.
Rebecca, I'm somewhat familiar with your team, and you're doing a master's degree, right? In health information management. You're a physician. And
I
you're
am a
doing-
physician, yes, but
And-
training went back for health informatics data analytics, and I'm finishing up the certificate part, and then we'll see the next step.
Great.
And regards from the team.
Thanks. Send them back.
Pleasure. My pleasure.
Okay.
Thank you so much for letting me present, and hope it helps. Thank you all.
Great. More questions? These are phenomenal studies, really. I think, I've done this over the years, and this is like the strongest group I've seen. It's really wonderful. No more questions? Last call. Okay, then you get my wrap up, which is the standard wrap up. Thanks for attending. Thanks to the AV folks. There's been, as you know, there's a couple of these presentations going on at the same time. So you may want to listen to the other videos before you do your votes. I'd have a hard time. I want to vote for all of you for the poster session, the People's Choice Poster Award. So with that, I will thank you. You're a wonderful, good-natured group. You've managed AV issues, and this is the first time we've done it. I hope I'll see you all next year. We will even be smoother about how this all moves. Okay, so have a great rest of the conference. Thanks so much.
Thank you, Ellen. Thank you.
Okay.
Thank you.